So my name's Pundrique Sharma, and I'm a consultant plastic surgeon at Liverpool. And for my paediatric practice, I work at Alder Children's Hospital in Liverpool. So to understand what pediatric nerve surgery entails, first you have to understand what nerves do. And nerves can be thought of as electrical cables that run from your brain all the way along your body everywhere, arms, legs, everywhere. And these electrical cables do two basic things. So number one, they give feeling to your fingers, to your hand, to your face, everywhere. And number two, they give movement to all the various parts of your body. There is a third thing that they only do when there's a problem, and that is they can give you pain. Okay, so that's what these electrical cables that we call nerves happen to do. So in general, when we do peripheral nerve surgery or pediatric nerve surgery, what we're trying to do is to find a way to fix the nerve. And there are a few basic, so a nerve that's not working. And that might occur because the nerve's been crushed, because the nerve's been cut, or because there's some pressure around it from some other reason. And it may have been stuck in scar tissue, which sometimes occurs after an operation for fracture fixation or something such. Okay. In terms of what we do, there are a few basic things that we can do. Firstly, we may simply release the nerve. Secondly, we might have to, so there's two cut ends, we can put the two cut ends together to fix the nerve. Or thirdly, we might do some kind of nerve reconstruction, which might mean taking nerve from somewhere else to effectively bridge the gap off the nerve that's missing if, for example, there's been a trauma or something such. Sometimes, for one reason or another, it's not possible to do the nerve surgery, right? It won't work. It's been too long since the injury or whatever it might be. And if that happens, then we have other techniques to move muscles and tendons and bones around to mimic the effect of trying to improve the nerve function. So in a way, it's easier to say when pediatric nerve surgery isn't indicated. So it would not be indicated when you've had an injury that's going to get better by itself, or alternatively, if you don't think there's going to be any merit in doing it because, for example, it's been too long since the injury has occurred. And we have a certain time limit when we can do that, which depends on the nerve that's been injured and where it's been injured and how it's been injured. When would it be indicated? Well, it's essentially indicated when we feel there's been a nerve injury that surgery will make better than nature will. That's the easy answer. But when that is massively variable because it depends on the nerve, when it's been injured, how it's injured, the age of the child, and a variety of other factors. So I think when I was training earlier on, so initially starting, I feel we were a little bit fatalistic about the outcomes of these reconstructions on nerves. But I think in children, generally speaking, they have surprisingly good outcomes. It is extraordinarily rare for us to operate on a child who's had a nerve injury, if we've made that decision to operate, not to get an improvement. So I would say well over 90% of children, once we made the decision to do the surgery, are better as a consequence of the surgery. Their function is better as a consequence of the surgery. Then there's a question of what is useful improvement, right? You don't just have to be a little better, you have to be enough better to have felt that the surgery is worthwhile. But actually, again, in children, I would say the vast majority of time, once we've made the decision to do surgery because we feel that it's not going to get better by itself and we haven't missed the boat, they will get better. I would say that's significant improvement. And I would say that's well over 80% of the children that we operate on for nerve injuries. So actually, I'm generally, if we can operate, relatively optimistic. Now, that has to be caveated with the fact that we're talking about improvements that make a consequential difference, not arriving at it being perfect. So we will not necessarily, unfortunately, always get a situation where it's as good as it would have been if there'd never been a nerve injury in the first place. And it's very important to understand that. So probably the risk that I worry most about is that it doesn't make a difference or a consequential difference. So that is top of my concerns and worries whenever I do this sort of surgery. Now, in addition to that, there are general risks common to any operation: infection, bleeding, the anesthetic, and so forth. But actually, I find that they're generally relatively low risks. The other risk, that's a particular thing with nerve surgery, is very often we're taking nerve from one place to move it to another place. So, and the place we take it from is called the donor, and where it goes to is called the recipient. So we have to take it from a place where we don't think it's going to be missed. You're robbing from Peter to pay for Paul. And you have to be sure Peter can afford it. And the problems that you get in the area where you take the nerve from. Now, in general, we pick it from places that can afford to lose it and don't have a consequential problem. But that is something very particularly you do have to be thoughtful and mindful about. So there's two things to think about in terms of, well, more than two things. There's several things to think about when you're thinking about recovery after peripheral nerve surgery. There's the immediate phase, there's the first few days afterwards, then there's the intermediate phase, which I suppose would be a few weeks, and then there's months down the line. In the immediate phase, usually children feel pretty well afterwards, pretty rapidly, and depending on the surgery, are either ready to go that day or within a day or two after surgery, even after surprisingly large surgery. Okay, that is to say, go home within that period of time. We're usually mindful about when they go back to exercise, depending on the type of reconstruction or surgery we've done. And over the next few weeks, we will either get them moving very, very rapidly if we don't want something to stick down, or if we're worried that something may be injured, we'll give them, around 3 weeks, give or take, in order for the reconstruction to settle in, for want of a better expression. So that's the kind of short and intermediate term. A lot of that is going to be directed by our therapists. We are very dependent upon our physiotherapists and occupational therapists, particularly in the children's hospital I work at, Alderhay, for supporting that recovery. It is without it, we wouldn't be able to do the surgery. It'd be pointless to do it. So then there's the longer term period, and in the longer term, the thing that we're really looking at is it getting better or not? And that's actually very difficult, because it can take months for you to notice an improvement. So it can be very, very stressful, both patient and doctor, while you're just sitting and waiting and waiting and waiting for that improvement to occur. And I think the big thing there is simply patience, a recognition that this is not something that you get an immediate hit on, but something that can often take a long period of time.